So our first lecture, we're going to be talking about fluid and electrolytes. So fluid and electrolyte balance is crucial to maintaining homeostasis within the body. Nurses play a very important role in regulating body fluids to ensure patient health, prevention, and treatment of conditions which result from fluid and electrolyte imbalances. This is something that as a nurse you're going to be working with on a daily basis. If you are treating patients that have their labs drawn, you're going to be monitoring fluid and electrolyte status. There's a narrow margin that's maintained, but illness or trauma occurrence can really create a shift in fluid concentrations, electrolyte distribution, as well as altering pH of both intercellular and extracellular spaces. So throughout this lecture and into the future ones, I want you to think about what kind of questions you're going to be asking your patient. How are you going to be conducting your assessments? This starts with something very simple. You can ask your patient how much they're urinating and so on. You're wanting to help maintain the balance in these individuals. And how does the body maintain fluid balance between fluid intake and output? So thirst is an important clinical sign that can be absent in older people. When fluid levels fall, blood pressure falls, triggering the release of renin from the kidneys. This promotes the formation of angiotensin II, which then stimulates the thirst center in the hypothalamus. The thirst center is also stimulated by a dry mouth, an increase in blood osmo, and lowered blood pressure. When the thirst mechanism is triggered, the usual response is to drink fluids to restore balance. Nurses should remember that some individuals, such as young children and older adults, will be unable to respond to this trigger and drink. Therefore, nurses should be offering these individuals fluids and assist them to drink as part of their nursing care. Without appropriate assistance, young children and older adults, and those with learning difficulties, are at increased risk for dehydration. Some examples of fluid loss or increased serum osmolality include dehydration, vomiting, diarrhea, exercise, increased perspiration, and the inability to take in fluids. Increased osmo can be related to increased salt or sugar levels in the blood, intake, or diabetes. Renal damage, poisoning, increased alcohol use, antifreeze, diabetes insipidus, and that's when the kidneys are causing a buildup of urea in the blood. So the kidneys are the primary regulatory of fluid volume and electrolytes within the body. They regulate the volume and osmolality of body fluids by controlling the excretion of water and electrolytes. The ability of the kidneys to make either concentrated or very dilute urine helps to maintain fluid balance. The kidneys work with various hormones to maintain fluid balance when extracellular fluid concentrations, volumes, or pressures change. Each kidney is made up of about 1 million filtering units called nephrons. Each nephron filters a small amount of blood. The nephron includes a filter called the glomerulus and the tubule. The nephrons work through a two-step process. The glomerulus lets fluid and waste products through it. However, it prevents blood cells and large molecules, mostly proteins, from passing. The filtered fluid then passes through the tubule, which sends needed minerals back into the bloodstream while it removes waste. The final product becomes urine. The volume of urine excreted daily varies depending on the amount of fluid taken in and the body's need to conserve fluids. The minimum amount of urine per day needed to excrete body waste is 400 to 600 mils. This is one of the many reasons why it's important, especially when you're in the clinical setting, to be documenting on your I's and O's. So if you are taking your patient to the bathroom, you want to make sure that you document that in Epic. I&O is a good indicator of your patient's fluid volume status. The renin-angiotensin-aldosterone system is a compensatory mechanism. Because the kidneys are a major regulator of water and sodium balance to maintain blood pressure and perfusion to all tissues and organs, the kidneys monitor blood pressure, blood volume, blood oxygen levels, and blood osmo. Think about your sodium concentration. When the kidneys sense that any one of these parameters is getting low, they begin to secrete a substance called renin. That sets into motion a group of hormonal and blood vessel responses to ensure that the proper pressure is raised back up to normal, hence a decrease in blood flow and pressure to the kidneys. Renin converts angiotensin in the circulatory system to angiotensin 1, which travels to the lungs and converts to angiotensin 2 by the angiotensin converting enzyme ACE. This is a potent vasoconstrictor to help raise blood pressure. This also stimulates the thirst mechanism and tells kidneys to retain sodium and water. Angiotensin 2 stimulates the adrenal cortex to release aldosterone, which promotes the retention of sodium and water in the nephrons of the kidney. So the goal is to restore that blood volume. Your antidiuretic hormone is a vasopressin. Let's say you're a normal, healthy adult who drinks the recommended amount of water per day. Then you change your routine for a week and you drink a lot less water than usual. Around the second or third day of the week, you go to the bathroom to urinate and you realize your urine smells really strong and has a deeper color of yellow than normal. The next day, you notice it smells even stronger and the color is a lot darker as well. Then you go back to drinking water as you normally do, and the smell and color of your urine becomes less intense and returns to normal. What you have just seen is the result of ADH, or antidiuretic hormone, at work. When you decrease your water intake, this decreases the amount of water in your bloodstream. Blood and other cells in your body need to be surrounded by just the right amount of water, so too little or too much in your body can be dangerous. Fortunately, we have a built-in alarm system of sorts. Any imbalance of water in the blood is detected. If there is a problem, the hypothalamus goes to work to correct things. So going back to the week when you didn't drink enough water, here's what happened. The hypothalamus detected potential dehydration and sent a signal to your pituitary gland, telling it to increase the amount of ADH being released in your bloodstream. ADH is released from the pituitary gland to act on the kidneys. The additional ADH reached your kidneys, telling them to decrease the amount of water to be excreted in your urine and increase the amount being put back into your bloodstream. This continued until the hypothalamus detected the normal amount of water in the blood. Along with altered blood pressure, other causes can cause this to release as well. Stress, pain, surgery, anesthesia, nicotine, and it's also inhibited by alcohol and some other medications. ANP is released by atrial muscle cells in response to fluid overload or increased arterial pressure. This action works by inhibiting renal sodium reabsorption and promotes diuretic through the augmentation of sodium. This blocks the secretion of aldosterone and water excretion action, suppresses the renin-angiotensin-aldosterone system and sympathetic nervous system. This produces arterial and venous dilation. This causes a decrease in blood volume through increasing urine output. The result, ANP, promotes sodium wasting and increased urine output. So next we're going to talk about fluid volume deficit. Fluid intake or retention that is less than what the body is needed to meet the body needs is fluid volume deficit. This results in a deficit from either too little intake or excessive fluid loss, or even a failure of regulatory mechanisms and fluid shifts within the body. Dehydration is commonly used and is interchangeable, but refers to water loss alone. The causes of this are excessive loss from GI fluids, vomiting, diarrhea, or GI suctioning, which we'll be learning about NG tubes later in the semester, intestinal fistulas, or intestinal drainage. Other causes include diuretics, renal disorders, excessive exercise, hot environment, hemorrhage, chronic use of laxatives or enemas, inability to access fluids. Think about those elderly patients or those stroke patients that can't move that water to their mouth, inability to request or swallow fluids, oral trauma, or altered thirst mechanisms, such as in your elderly individuals. So your older folks are particularly at risk for this. The result is a decrease in circulating blood volume. Typically, electrolytes are also lost with fluid volume. The body attempts to maintain tissue perfusion by pulling interstitial fluids into the vascular system and stimulates regulatory mechanisms. What occurs is increased thirst, ADH, and aldosterone released, signaling the kidneys to retain sodium and water. Some nursing interventions that you'll see for this are going to be your IV fluids as ordered. You're always going to monitor your I&O, and you're going to intervene with creative ways. You're going to enlist your family members. They're also a very important intervention. You can enlist them to help give fluids to your patient, help encourage, maybe ask them questions about what your patient likes to eat and drink. That helps a lot too. So with fluid volume deficit, you're going to see some manifestations during your assessment. Your skin turgor really diminishes and it causes tenting. You're going to have some orthostatic or postural hypotension. And this is a drop of 15 or more in their systolic blood pressure when changing from a laying to a sitting or from sitting to standing position. This indicates a loss of intravascular volume. You might also see flat neck veins due to loss of venous pressure, anxiousness or restlessness, fatigue, and if it's severe, you're going to have decreased responsiveness or confusion, especially in your elderly. You might also see pale or cool extremities due to vasoconstriction, decrease in the urine output, and sudden weight loss can happen at times too. Might be sudden, might be gradual. And mucous membranes may be covered in a thick, sticky coating, and they might have cracks or fissures in there. Oral care is very important with these patients. And then a temperature loss due to a loss of blood flow to the brain. So no single lab result test confirms or rules out dehydration. Instead, dehydration is determined by laboratory findings along with your clinical manifestations. So with your electrolytes, you're going to see an increase of sodium and a loss of potassium. Hemoconcentration does not occur when hemorrhage is the cause due to loss of all the blood and the plasma products together. And this image right here is a really good one that shows you how your H&H, your hemoglobin and hematocrit, are going to be increased due to loss of volume. So it's over-concentrated. So when you see the normal cells, they're all nice and spread out. As you get more dehydrated, you have this loss of fluid here, and there's still the same amount of red blood cells as long as you haven't had a hemorrhage, but there's less fluid volume in there, so they're going to be more concentrated. So the focus of management for patients with fluid volume loss is prevention of injury. So that's where you're going to prevent kidney failure. Prevention of further fluid loss and increase the fluid volumes back to normal. So fluid replacement is the key in establishing effective perfusion. Oral rehydration is the safest and most effective treatment for fluid volume deficit in alert patients who are able to take in and retain fluids. You want to shoot for 1.5 liters of fluid a day, or 30 milligrams per kilogram. Fluids must be replaced gradually. If fluid loss is minimal, water alone can be used. If it's more severe and electrolytes have also been lost through vomiting or diarrhea, a carbohydrate electrolyte beverage is more appropriate. IV can be used when the deficit is severe or they're unable to ingest fluids. The isotonic or the 0.9 normal saline or ringer solution, normal saline tends to remain in the vascular compartment, increasing your blood volume. The hypotonic solutions, such as your D5.5 or your half normal saline, provide water to treat total body deficits. D5 is not routinely used because dextrose is rapidly metabolized and then the fluid is hypotonic, even though it's considered an isotonic solution. So what are your responsibilities as the nurse? You're going to identify patients with risks, carrying out your interventions, and monitoring the effects of the treatments. For health promotion, you're going to be educating your patients regarding prevention. Think about your warm weather and your exercise, or even your illness. You're going to educate your patient about maintaining hydration during these events. So you're going to monitor your patients with intake and output during periods of loss, vomiting, NG suction, diuretic use, and wounds. This is when it's important to document your I&O. Your assessment, you're going to take a health history, identify risk factors such as medications, think about your diuretics, renal disease, hot environments, and access to fluids, any types of recent illness. Your physical assessment, you're going to weigh your patients every day. You want vital signs with orthostatic. You're going to be looking at their skin color, temperature, and turgor. You're going to be assessing their level of consciousness, their mentation. Don't forget about their urine output again. In orthostatic, the amount of time that you wait with taking that is about a minute. So when you're sitting your patient up, you're going to wait a minute, then take their vitals, take their blood pressure, and then you're going to stand them and you're going to wait again and then take it because you're giving the body time to adjust. So what is the nurse's priority? That is restoring adequate fluid volume to support tissue perfusion and organ function. So what can be some of your interventions? For fluid volume deficit, you're going to be looking at their urine output. You want it to be 30 to 60 cc's per hour for an adult. You're going to be weighing your patient again, intake and output, administering IV fluids, monitoring for overload, lab values, electrolytes, serum osmo, and your BUN. For ineffective tissue perfusion, fluid volume deficit, you want to look at decreased renal perfusion, cerebral and peripheral tissues. Monitor changes in their level of consciousness, mental status changes such as restlessness or anxiety, confusion, agitation. Labs, their BUN again, cardiac enzymes, and you're going to notify the healthcare provider. You also want to provide turning and good skin care. Risk for injury, that's going to be because of dizziness. They might have balance changes with orthostatic hypotension or decreased cerebral perfusion. Safety precautions, reduce the effects of orthostatic hypotension. You want to move in stages. That's where you're sitting for a little bit to kind of let the body adjust. And then prolonged standing, you really want to avoid that. You want to get them in the recliner through the day and use your assisted devices. They're there to help you. So fluid volume excess is due to retention of both water and sodium by the body. Fluid overload from intake or altered homeostasis mechanisms. Retention of both water and sodium. The sodium and water are gained in equal proportion, keeping the excess fluid in the extracellular space. Some of the causes can be heart failure, cirrhosis of the liver, renal failure, adrenal gland disorders, corticosteroid administration, stress, which causes the release of ADH and aldosterone. Surgery is a major cause of that. Intake of sodium, drugs, excessive IV fluids like 0.9 or Ringer solution. And again, surgery, that's the stress response that leads to release of aldosterone and ADH. This causes an increase in retention of water and sodium. It tends to remain interstitial, but reabsorbed into circulation about 48 hours to 72 hours post-op. So with fluid volume excess, we have an excessive amount of ECF. That's hypovolemia and circulatory overload. The excess in interstitial fluid causes peripheral and generalized edema. So with the edema, you're going to have peripheral excess in the interstitial spaces. This is usually due to heart failure, renal failure, or stress, that surgery response. You're going to have bounding pulses, neck vein distension, and increased CVP. For respiratory effects, you're going to have dyspnea at rest, orthopnea while laying, a decrease in O2 saturations, moist crackles upon auscultation, and that's going to be from fluid in the interstitial spaces in the alveoli. You're going to have altered gas exchange from the pulmonary edema. So you're going to also have tachycardia and hypertension because of an increase in circulatory volume. Increase in urine output, the increase in volume increases the glomerular perfusion, and then ascites, that's your fluid moving into the interstitial space. Altered mental status and anxiety, that's going to be your pressure on your cerebral cortex from cerebral hypertension and edema causing decreased oxygenation of the neurons. So some of the other things you can look for is weight gain, pitting edema, And that's going to be a really good picture here that shows the different stages of pitting edema. So what are the main goals of correcting fluid volume excess? We want prevention of those at risk, treatment of the manifestations, and correcting any underlying causes. You're going to be looking at your labs, your electrolytes, your serum osmo. You're going to be keeping an eye on the H&H, and that's going to be decreased because of dilution. And renal and liver enzymes may also give a good indicator of what the cause of this might be. So your diuretics are going to be the most common treatment by inhibiting reabsorption of water and sodium and stimulating urine output. There are 3 different types that work in the different parts of the kidney tubules. You've got your loop, and that's going to be excreting sodium, chloride, potassium, and water. And examples of those are Lasix and Bumex. Your thiazide type, and that's going to be doing about the same with your excretion there. It just works in a different part of the tubule, and that's going to be your Diuryl and your Zeroxylin, and then your potassium sparing, and that's going to excrete sodium and water. That's your Aldactone, and that inhibits any sodium-potassium exchange. That being said, you really want to monitor those potassium levels in those first 2 types. Your treatment and nursing care for those at risk. You're going to be increasing health promotion, especially for those with heart failure and renal failure. You want to educate them on the relationship between sodium and water. You want to tell them about a low-salt diet. You read food labels and really pay attention, especially to those processed foods. A lot of times they are higher in salt content than things that are homemade. You're going to educate your patient on daily weights. They're going to be weighing themselves on the same scale, the same time of day, preferably in the morning, and then wearing the same type of clothing. And you're going to have them notify the doctor if they gain more than 3 pounds in one day or 5 pounds in 1 week. That being said, if you're taking care of a patient and you notice that they've had a 3-pound weight gain while they're in the hospital, you're also going to be notifying the physician of that as well. For your assessment, you want a health history, look at their medications, chronic medical diagnosis, heart failure, renal failure, any type of recent illness or dietary changes. Sometimes these patients will go to a party and eat the food that's prepared there, and all of a sudden they have a CHF exacerbation from too much salt intake. So for physical, you're going to be looking at their weight, their vital signs, their pulses. Do they have distended neck veins, altered respiratory patterns, or lung sounds upon auscultation? You'll be looking for crackles or wheezes, any dyspnea, cough, sputum, edema, urine output, or mental status changes. As a nurse, we must monitor the effects of fluid administration as well, because sometimes when you're giving fluid for a fluid volume deficit, you're going to put them into overload, trying to correct the issue. So if your patient is suddenly tachycardic with bounding pulses, increased edema, and some crackles and requiring oxygen, you got to think about what you'd be doing for those patients. So for fluid volume excess, we're going to be assessing their vital signs and their heart sounds. You're going to be looking for that S3. Edema, particularly in the lower extremities, in the back and the sacral area, and any periorbital edema. Dependent areas, the lower extremities for ambulatory patients, sacral area for bedridden, and periorbital would be more indicative of generalized edema. Daily weights. We're going to be talking about daily weights a lot in this class. It is one of the most important gauges for fluid volume balance. We want to look for consistency in our weights. Administer any type of oral or IV fluids cautiously. Encourage oral hygiene. Keep those membranes intact, and it helps quench thirst. This is very important for patients that are on a fluid restriction. Oral care is very important. Sodium restricted diet. These are going to be your patients that say that the hospital food has very little flavor, and they're going to be wanting to add salt to it. Don't give it to them, because that'll make the problem worse. Read the labels, and again, watch out for those processed foods. Follow the physician's directions on taking diuretics, physician or the other providers like your PA and your nurse practitioners. Renal function, keep an eye on their skin integrity. Edema can cause a decrease in oxygen and nutrient delivery. Assess their skin, especially in pressure areas over bony prominences due to impaired circulation. Reposition them every 2 hours or more often. This minimizes tissue pressure and promotes blood flow to tissues. Use alternative mattresses. There's a couple different varieties that we carry at Unity Point. Use your heel protectors and redistribute pressure away from those areas. You want to look out for impaired gas exchange due to edema in the pulmonary interstitial tissues. Auscultate your lung sounds, looking for crackles and wheezes. Identify any pulmonary congestion and edema. Look for a gallop and S3 that indicates diastolic overload. And then monitor their oxygen levels and get ABGs if you need to. Edema interferes with gas exchange to the body tissue. So these are some of the signs that you might see with these patients. So we're going to talk about sodium here for a little bit. And the normal range for sodium is going to be 135 to 145. It is the role of it is the primary regulator of volume. It controls your osmo, your distribution of your ECF, and neuromuscular activity. Sodium imbalances affect osmo of ECF and water distribution between your fluid compartments. And remember the role of the kidneys in this that we talked about earlier. The role of renin, angiotensin 1, angiotensin 2, the ADH, and the ANP as well, because that has some effect on it too. So hyponatremia is when your sodium is less than 135. Usually this is from loss of sodium from the body or water gain that dilutes the ECF. Additional causes can be neurological conditions, caused by cerebral salt wasting, excessive sweating, loss from skin surface, like in your burn patients, third spacing, excessive administration of hypotonic solutions, water shifts from ECF, and interstitial spaces. The manifestations of this is going to depend on how fast this occurs. If it occurs slowly, you might not notice until the level's about 125 or lower. Early, you're going to see some muscle cramping, weakness, fatigue from the effects on the muscles, anorexia, nausea and vomiting, and some abdominal cramping. As it decreases, you're going to have brain and nervous system affected. You're going to have some headache, depression, irritability, lethargy, hyperreflexia, and some muscle twitching. You could also be seeing some tremors and some confusion. I've seen some confusion in patients with low sodium. The treatment with loss of both water and sodium, you're going to be giving sodium-containing fluids. That's going to be your 0.9 normal saline or your Ringer solution. With extreme causes of sodium levels, they're going to do the 3% normal saline. If due to excessive ECF, they're going to give loop diuretics, and that promotes an isotonic diuresis and fluid loss without causing any hyponatremia. If it's mild, we can increase the intake of foods high in sodium, and we can do a restriction of fluids to reduce the ECF volume. So if you have a patient with GI loss, will they lose some sodium? Absolutely. So when these patients come into the emergency department with their vomiting, they may also be having some muscle cramping in addition to that. So with hypernatremia, these are going to be your levels greater than 145. This is usually due to water loss and excess of sodium, but can also be due to excessive sodium ingestion or administration. They're going to be thirsty as their body wants to dilute that sodium levels. There's two mechanisms to protect the body from hypernatremia. An increase in sodium stimulates the release of ADH in the kidneys to retain water, and the thirst mechanisms are triggered to drink. So what happens when this occurs? An increase in EC water and dilution of extra sodium, and that helps to equalize back to normal levels. So thirst is going to be your first symptom of hypernatremia. And if it's not sufficiently met, the body compensates by drawing water from the cells. The brain cells contract and neurological manifestations develop. That's when you're going to get lethargy, weakness, irritability, and that can progress to seizure, coma, or even death. Symptoms depend on the severity and how fast this happens. The brain will attempt to compensate, but if rapid onset, when extreme symptomology will occur. So why would your older adults be at risk? Due to diminished thirst or access to water. So your treatment's going to be oral, enteral, or IV water replacement with the hypotonic solutions. That's your half normal saline or your D5W. That's isotonic, and initially when the hypotonic, and then hypotonic when the glucose is metabolized. Diuretics are used to increase sodium excretion, and the prevention is offering fluids to those who are unable to provide their own and encouraging the elderly with decreased thirst drive. So this is a slide that just kind of shows you the difference, and I've also uploaded a PowerPoint with just these graphics on there in case you just want to look at those alone. So next we're going to talk about potassium imbalance. So this is primarily an intercellular electrolyte that assists with cellular metabolism and cardiac neuromuscular function. Normal levels are 3.5 to 5.3. To keep in balance, this must be replaced through diet daily, and most all foods are going to contain potassium. Imbalances disturb the resting potential of the nerve and muscle cells, and this affects transmission and conduction of nerve impulses, potentially altering normal cardiac rhythm and contraction of smooth and skeletal muscle tissue. Acid-base balance is disturbed when potassium shifts in and out of cells. And your sodium-potassium pump is what maintains the higher ICF levels of potassium. So your foods that are going to contain the most amount of potassium are going to be your bananas, your oranges, avocados, spinach, potatoes, tomatoes, meat, seafood, milk, and yogurt. There's a lot of other foods out there that are really high in potassium, including prunes, which are really high in potassium, and then beets, squash, beans, mushrooms, nuts, and salmon. These are important foods to remember when we start talking about renal disorders, because there are a lot of times when people are on dialysis, they really need to control the amount of potassium that they have in their diet. So hypokalemia, that's when you have an abnormally low potassium level that's less than 3.5. Usually this is due to potassium loss, but it also can be influenced by lack of potassium intake. Other causes include excessive renal or interstitial loss, redistribution of ICF and ECF, like when you have diarrhea or perspiration, and then your potassium-wasting diuretics, corticosteroids, large doses of antibiotics, stress, trauma, magnesium deficits, ileostomies, and insulin. When you're talking about insulin, that moves potassium into the cells as a means to treat diabetic ketoacidosis. And some IV fluids and laxatives can also cause hyponatremia. You need about 40 to 50 milliequivalents of potassium a day to compensate for urinary loss. For your symptoms, it's going to depend on the severity or the speed of your onset. With more gradual, the body compensates by shifting out of the cells, and the manifestations are less significant. Your treatment is going to be oral or parenteral potassium supplements and the replacement of ongoing losses. So what are some of your nursing considerations? You want to dilute any oral liquid potassium, give it with food, and if it's IV, infuse it slowly over 10 milliequivalents per hour. Never give it IV push. So it needs to be diluted, and you want to look out for pain at the peripheral insertion site. We want to do a slow administration and always use a pump. So diuretics are always going to be a concern. So if receiving any type of potassium wasting diuretics, you want to make sure that you're monitoring these levels. So with your diuretics, think potassium, and with potassium levels hypo or hyper, you want to make sure that you're watching out for any type of EKG changes as well. So you might want to be asking for scintilometry. Again, here's another graphic for you to look at, and I did load this onto a separate PowerPoint so you'll have more time to look at it. So next we're going to be talking about hyperkalemia, and this is a potassium level greater than 5 or 5.3. This is usually from inadequate excretion of potassium, excessive intake, or a shift of potassium from the ICF to the ECF. And that affects neurotransmitter and cardiac function. So the primary cause of this is going to be impaired renal excretion. So it's going to be untreated renal failure, adrenal insufficiencies like Addison's disease, or inadequate aldosterone production. Medications can also cause this, like potassium-sparing diuretics, ACE inhibitors, or angiotensin blockers. So the rapid administration of potassium can affect this acidosis, and that's where the potassium shifts from the ICF, and it can also occur in burns, trauma, and starvation. So your symptoms, your effects are going to be a muscular contractility, and that's going to be first in your cardiac. So it's going to be slowing your heart rate, causing heart blocks and EKG changes. Could be ventricular dysrhythmia or even cardiac arrest. So anybody with potassium abnormalities, if they're pretty significant, I would be asking the provider for telemetry to monitor that heart. So with early manifestations, they could be having diarrhea, colic, that's going to be the abdominal cramping, anxiety, irritability, and muscle tremors. As these levels increase, they're going to have muscle weakness, flaccid paralysis, bradycardia, and arrhythmias. So the treatment, you're going to first want to make sure you're identifying the cause and educate on intake. If it's a renal function issue, you're going to be giving diuretics. Calcium gluconate to counteract the effects of potassium on the cardiac system, and to rapidly lower administration of insulin and glucose to move the potassium into the cells. So to remove from the body, you want to be giving some K-oxalate per the provider order, and that binds to potassium in the GI tract. That can be given orally or rectally, and when it's a renal function issue, they may be putting these patients on dialysis. Another graphic for you. And again, these are going to be loaded into that other PowerPoint. So if you're looking at this top one is going to be your normal EKG. This one right here, you can see a flattened T wave, and that's usually present with ST segment. And that's going to be your hypokalemia, your low potassium. And then down here, you've got your hyperkalemia, and that's going to be your tall, tented T wave and wide QRS, prolonged PR interval, and ST segment depression. So those are some examples that you'll see with hypo and hyperkalemia. So then we have calcium imbalances. So the normal concentration of calcium is going to be 9 to 11. And that's obtained from dietary sources. We only need a small amount absorbed into the bloodstream, but it's excreted in feces and urine. 99% of this is bound to phosphorus to form the bones and teeth. The remaining 1% is in the ECF, and half of this is ionized or active. And that helps to stabilize cell membranes, regulating muscle contraction and relaxation, and helping to maintain cardiac function and blood clotting. Serum calcium is regulated by the parathyroid hormone, calcitonin, and calcitrol. When calcium levels are low, the parathyroid hormone moves calcium from the bones, and it's reabsorbed by the intestines and kidneys, while calcitonin responds to elevated levels and helps inhibit movement out of the bones and decreases reabsorption, promoting excretion by the kidneys. Vitamin D also helps promote calcium absorption, and the natural form is, of course, sunlight. So hypocalcemia, or low calcium levels, that's your below 9. And this results from decreased total body calcium stores or decreased EC, calcium with normal calcium stores in the bones. Other causes can be your parathyroidectomy, your thyroidectomy, lactose intolerance, alcoholism that decreases interstitial absorption and intake, malabsorption due to intake, decreased dietary intake, inactivity also causes bone loss, medications like Lasix or anticonvulsants, Dilantin and phosphates, and decreased estrogen levels such as in menopause. Renal failure can also cause issues with these and massive blood transfusions. So the most serious manifestation you're going to see with this is going to be tetany. Calcium has a stabilizing or sedative effect on neuromuscular transmission, and hypocalcemia increases neuromuscular excitability, cause twitching, spasms, and tetany. Paresthesias, which are going to be your altered sensations because nerves become overexcited. Nerve muscles are stimulated, causing dysrhythmias like ventricular tachycardia or cardiac arrest, and decreased cardiac output. Numbness and tingling around the mouth, hands, and feet, and laryngeal spasms, airway obstruction. So those are all things that you're going to be looking at with these. Another nice little graphic for you. So the decrease in calcium levels cause release of parathyroid hormone from the parathyroid gland. The bones then release calcium, increased absorption of calcium into the intestines, and increased reabsorption of calcium by the kidneys. Many times with low calcium, you're going to see a decrease in magnesium level, and you may need to treat mag to get the calcium levels to come up, increased phosphate and PTH. So with treatment, you're going to go with oral or IV, vitamin D to help assist with absorption of calcium in the GI tract, and encourage a diet high in calcium, dairy products if they can tolerate it, canned salmon, broccoli, spinach, and tofu if they're able to have that. So I will put this sign on the slide on the other PowerPoint so you can watch these videos. There's a couple of good links in here that go over Chvostek sign. So some of the indicators of hypocalcemia with low calcium levels include those muscle spasms we talked about, and that's going to be in your face and your extremities, and occur with deep tendon reflexes becoming hypersensitive. So the Chvostek sign is a contraction of the facial muscles that's produced by tapping on facial nerves in front of the ear. And I would encourage you to take a look at these videos. And then the Trousseau sign is a carpal spasm that's induced by inflating a blood pressure cuff on the upper arm to above systolic blood pressure for 2 to 5 minutes to elicit increased neuromuscular excitability in patients with manifestations. We're going to continue lecture talking about calcium. Make sure that you check out the graphics PowerPoint and click on this link here to take a look at those videos. So hypercalcemia are going to be serum calcium levels greater than 10. This can be due to increased reabsorption of calcium from the bone, and that's when it leaves the bones due to hyperparathyroidism and sometimes malignancies. PTH excess signals release of calcium from the bones and increased absorption by the intestines and retention by the kidneys. This is common with malignancies because of bone destruction by the tumor or tumor-expressing hormone. Excessive vitamin D, antacids, and milk product intake as well. Some diuretics like thiazides and lithium interfere with excretion by the kidneys. Hypercalcemia decreases neuromuscular excitability, leading to weakness and depressed deep tension reflexes. The kidneys are unable to concentrate urine because hypercalcemia causing sodium and water loss and increased thirst. Complications can be gastric ulcers due to increased gastric acid secretion, pancreatitis because of calcium deposits, and kidney stones related to excess calcium precipitate. Treatment is going to be IV with isotonic fluids, with loop diuretics that help promote elimination of calcium, medication to prevent bone reabsorption loss, such as Reclass, Zometa, and so on. Emergency situations, they can give IV phosphate to help bind that calcium, and glucosteroids to help compete with vitamin D. And then calcitonin and phosphorus increase renal output of calcium and phosphorus. Here's another graphic for you on the two differences. Then we're going to be talking about magnesium imbalances. So the normal range for this is 1.8 to 3. Magnesium is obtained through the diet, and it's plentiful in greens, vegetables, grains, nuts, meats, and seafood. It's essential for neuromuscular transmission and cardiac function. Physiological effects of magnesium are affected by both potassium and calcium. So hypomagnesemia is going to be a range less than 1.6. This is going to be common in your critically ill patients due to deficient magnesium intake. You got to think about your patients that are malnourished. They could have excessive loss or a shift between the ICF and the ECF. There's multiple risk factors for this, including alcoholism, deficient intake, increase from GI loss. Think about your patients that have GI issues like vomiting, impaired absorption, and increased renal excretion. Medications can also cause this, like loop diuretics or thiazide, aminoglycoside, antibiotics, and cyclosporins. Be aware, too, that magnesium deficits can occur also with potassium, low potassium levels, and calcium levels. So a lot of times if you're having a hard time maintaining a patient's potassium level, you're going to check their mag and find out that they also have a low magnesium level. This causes increased neuromuscular excitability and muscle weakness, and as well as tremors. You're going to have increased neuroexcitability that contributes to seizures and mental status changes. Be aware that there could also be cardiac abnormalities, dysrhythmias, and an increased risk for digoxin toxicity and hypertension. So these patients are going to have tremors, hyperreactive reflexes, positive Chostak sign and Trousseau signs, those videos that you saw, that's tetany, paresthesia, seizures, confusion, mood swings, hallucinations, and an increased heart rate. They're going to be tachy. They'll have tachycardia. So the treatment's going to be adding magnesium to parenteral nutrition if they're malnourished. Intake in foods, you want to increase their green leafy vegetables, seafood, milk, bananas, citrus fruits, and chocolate. And then they can have oral magnesium supplements as well, or IV. So then we're going to have the high magnesium, the hypermagnesia. And that's going to be when their levels are greater than 2.6. This is less common, but it can develop from renal failure, especially if they're taking supplements, and it's typically older adults. So if they're using over-the-counter laxatives, you need to be aware of that as well, especially with patients with renal function. So think about it this way, milk of that has magnesium in it. So you want to be careful with those patients that have an increased risk of laxative use with impaired renal function. Another graphic for you. So then we're going to talk about phosphate imbalances. The normal range for this is 2.5 to 4.5, and phosphate is essential in production of ATP, and that's, of course, the fuel that supports muscle contraction and nerve cell transmission and electrolyte transport. It's vital to red blood cell formation and O2 delivery to tissues, nervous system and muscle function, metabolism of fats, carbs, and proteins, and it helps to maintain the acid-base balance. So it's ingested in diet, it's absorbed in the jejunum, and excreted by the kidneys. When intake is low, the kidneys will conserve this and vice versa. So this is inversely proportionate with calcium, so that means if the calcium levels go up, the phosphate levels go down. Regulatory mechanisms for calcium levels include parathyroid hormone, calcitonin, and vitamin D. So hypophosphatemia, or low phosphate levels, are going to be a serum level less than 2.5. The most common cause of this is a shift from the intercellular space. This can be from decreased absorption of phosphate or increased renal excretion. It's Often related to treatment, think about refeeding syndrome. That stimulates insulin release, which prompts movement of glucose and phosphate into the cell, and that depletes the ECF. Other causes can be medications like IV glucose, antacids, and the antacids are because of aluminum or magnesium binding to the phosphates, anabolic steroids, and diuretics. Alcohol also affects absorption of phosphates. You want to be aware of that when you're working with chronic alcohol use. Also, respiratory alkalosis due to hyperventilation as it shifts phosphates to the ICF, stress, and burns. And then you can see some of the manifestations over there on the right. So muscle weakness, paresthesias, confusion, bone pain, joint stiffness, bleeding disorders, impaired WBC function, seizures, anorexia and dysphagia, and of course nausea and vomiting. And I want you to think about why some of these would happen. So lastly, we're going to be talking about hyperphosphatemia, and that's going to be your high phosphate levels of greater than 4.5. And this can be due to impaired excretion, excessive intake, and a shift from the ICF to the ECF. Renal failure is going to be your primary cause, phosphate enemas, excessive vitamin D with impaired renal failure, and then sepsis, chemo, and trauma. So the treatment for this is going to be elimination of intake of phosphate-rich foods. That's going to be your organ meat, your milk products, and then agents will be given to bind with the phosphate in the GI tract, such as calcium-containing antacids. And again, a nice little chart for you. And these are on a separate PowerPoint again. And this just shows the different relationships between the electrolytes. This is something that's really important to remember as you move into your nursing career, because anybody that has an imbalance with one electrolyte is likely to have an imbalance with one of the other ones. And I think I mentioned before about, let's see, this one right here. This one is notorious. So if you have troubles with potassium levels and you're treating your patient and nothing is working, you always want to make sure that you get a MAG level on them as well. So some key points to remember for the exam next week. You would want to know each one of the disorders, the causes, the manifestations, what your assessment's going to be, your priority, and then your interventions and treatments. You want to know your body systems, your relationships, that's the inverse, proportionate, and the similar one. And then going to be some math on there too, and then that's just a link to study tips there. And here's a nice little cheat sheet for you. One thing to remember about sheets like this, because I got this off the internet, is to make sure that it corresponds with the values in your book. Most of them are pretty similar, but just go through, if you print this off from the other PowerPoint, go through your book and make sure that you're updating it with the appropriate levels. That completes today's lecture on fluid and electrolytes. If you have any questions, make sure that you email me, and I will get back to you within 24 to 48 hours. Have a good week.